it is so lovely to be here with all of you. And I think the work you do is so valuable and so incredibly important. And our training today is kind of going to focus on two different areas of grief. And I invite all of you to ask questions at any point if you're curious or want to learn more about something. Just a little bit about me. So my sort of paying job that kind of pays my bills and keeps a roof over my head is I'm a clinical director of a perinatal mental health counseling center. So we essentially see clients that are experiencing anything within the reproductive time frame, ranging from trying to conceive, infertility, pregnancy loss, infant loss, and then of course pregnancy and postpartum mental health concerns, perinatal mental health disorders, and birth trauma and the like. So today though, we're going to be really focusing on grief and loss, and I'm going to explain what that looks like, hopefully throughout this presentation. So, like I said, today we're going to be talking about grief and loss. And oh, I neglected to mention my very busy non-paying job, which is I'm on the board for Postpartum Support International, New Jersey. And I engage in community outreach and engagement, where we provide resources and support, exactly like what I'm doing today, to the community and different community organizations and hospital networks, et cetera. So today we're going to be talking about, like I said, grief and loss, but we're going to be talking about it from really two different perspectives. The first one we're going to be focusing on is reproductive and perinatal grief and loss. And then sort of later on, we're going to be talking about the grief and loss that comes with learning about your child's diagnosis. So one of my most favorite lines in the entire world is from Brené Brown, which is, "What we don't need in the midst of struggle is shame for being human." And I love this because so much of what our families are experiencing is so normal given the abnormal circumstances. And they don't need to be shamed for that. And just recognizing and holding space for the fact that they're human and they're going through something is so valuable and important throughout this period. So, like I said, we're going to be starting off by talking about grief and loss. And, you know, understanding a little bit of the different kinds of losses is important. And I recognize that this is not necessarily so relevant to the work that you do, depending on the kinds of work that you do, the kind of work that you do, rather. But it is important to know that the families that you're going to be working with, the parents you work with, may be experiencing one of these things rather. So the failure or unsuccessful IVF cycle, right? So there's that loss of an embryo, right? A molar pregnancy is a sort of like a tumor that develops and which kind of leads to a unsuccessful pregnancy. Recurrent pregnancy loss is when somebody has 3 or more losses. Selective reduction is when a person is pregnant with, say, more than one fetus, and they have to reduce the pregnancy to either being 2 or 1 or whatever number they have. Ectopic pregnancy is when somebody gets pregnant outside of the uterus. A chemical pregnancy is a pregnancy before 5 weeks. Is a pregnancy loss before 5 weeks. Abortion, that is when, I'm sure all of you know here, right, is when a person chooses to end a pregnancy. Stillbirth, that's when a baby is born. Not living. Some people say sleeping, but the term is typically not living. And that can happen, you know, beyond, also earlier on in the pregnancy. A miscarriage, termination for medical reasons is when a baby is incompatible with life, or they will have a long-term illness that the parent chooses to terminate. Neonatal and infant death, that can be when a baby is living for, you know, a minute, and dies, or infant is when they're obviously a little bit older, or can also be, you know, during infancy. And then the loss of an embryo, right? So just understanding how in the perinatal period, there are many different kinds of losses. And these losses can certainly impact your family regardless of what they are. And, I'm sure many of you have heard about this term disenfranchised grief or ambiguous loss. And this is sort of the loss that, the person is not necessarily experiencing a loss in the way that is sort of going to, like, so to speak, like the typical or socially acceptable, socially validated rather, losses. So for example, it's not necessarily publicly mourned, right, or acknowledged. Um, so really, any of these that I just mentioned can be considered disenfranchised grief or ambiguous loss, where a person who lost an IVF cycle, right, or a person who experienced recurrent pregnancy loss. First of all, many people may not have even known that they were pregnant, but at the same time, we don't have a funeral service for the loss of a very, very early on, miscarriage, even stillbirth. Many people don't choose not to have funeral services for that, right? And it's very, very difficult when they don't have necessarily memories associated with it. There's no socially, so to speak, acceptable way to really grieve and mourn this loss. And for the bereaved, right, this grief is just as real for them as others who have lost parents, grandparents, older children. The grief can feel just as real, regardless of the kind of loss. And many of them will experience isolation and loneliness because perhaps the world doesn't necessarily see their grief as being valid. And many of them will then sort of, internalize this as shame, and also that they're not allowed to sort of feel this grief because it's not being socially recognized, and people aren't acknowledging their grief and pain. And I just wanted to add too that with disenfranchised grief, the important thing to remember as well is that when it comes to later on when we talk about diagnoses and learning about your child's diagnosis, disenfranchised grief is very, very relevant in those cases. So I really want to take a moment to talk about depathologizing grief, because unfortunately, I don't know, how many of you are familiar with this, but there in the DSM-5 TR, so like the updated version, they created a new diagnosis called prolonged grief disorder, which is very disheartening to many of us in the field, because grief is not a pathology. It's rather a very natural and normal response to a very traumatic loss, right? Any grief that a person experiences is not pathology. And we can talk about another day, like functionality, like if a person's completely not functioning, but we're focusing here on today, the fact that grief is not a pathology and we don't move on from it, right? That infant, that baby, that embryo, right? So if somebody loses an embryo and they had 8 embryos, right? That will always hold that placeholder, right? They had 8 embryos and now they have 7. Likewise, when a person loses a pregnancy, right? Whenever they go to the doctor's always going to ask them, how many pregnancies did you have? And it's always going to be, I had 1 or I had 2 or whatever it is. So that placeholder is always going to be there. We don't move on. Rather, we move forward with our grief. And there's no expiration, right? Grievers can sometimes be perceived or seen as mentally ill or unstable. And really, grief is an expression of love that has nowhere to go. Right. We grieve because we love, and because loving a baby or loving a potential baby never ends, so too grieving the loss of a baby will never end. And people really tend to pathologize grievers since they don't want to believe that something that bad can happen to them. So if I have to feel pain in order for me to empathize with you, right, that's going to be really uncomfortable and difficult for me, because then I have to think about the idea that I could also potentially lose a baby. And I don't want to think about that. That feels too painful. So instead, I'm just going to avoid and pretend that this doesn't exist, right? We as a society aren't aren't well equipped and don't do a great job at really showing up for the bereaved. Rather, we avoid because we are so uncomfortable with having to imagine that something that bad can happen to us. So I just want to take a moment to, sorry, just something popping up. Okay, I just want to take a moment to really talk about the parental identity. And I just want to acknowledge that the loss of a child, right, a potential child, right, so even like the loss of an embryo, is considered the most unnatural and intensified, physiological and also psychological moments of distress, right? Particularly in mothers. This is obviously a very, very unnatural experience and will certainly and almost in all cases be considered traumatic in nature, right? So not all grief is traumatic, but all trauma does come with an element of grief. And certainly the loss of a child, the loss of a potential child will always be considered traumatic. And there's a question that sort of people struggle with, which is like, who am I without my living child? Right. And somebody had once shared with me, she said, I don't have an excuse to be, carrying all this baby weight when I'm not pushing a carriage. Right. And it's really important to recognize that these folks are still considered postpartum. So typically in the cases of, when a person's, let's say, breast milk comes in, or say when they are experiencing a stillbirth, right, or they experience a stillbirth, they're still considered postpartum and they're still considered parents. And so often we unfortunately tend to kind of forget the fact that they're considered parents and we don't acknowledge them. And I see how somebody wrote about Mother's Day, right? And I know that they sort of started this trend of having bereaved Mother's Day, but actually many of my clients share with me that they despise bereaved Mother's Day because they want to celebrate Mother's Day just like everybody else. They too are a mom. And just because their child isn't living doesn't mean to say that they're not a mom. So just acknowledging how Mother's Day can be so triggering or activating for so many parents. And people often forget that, the other bereaved parent in the room, the non-birthing person or the father, right? Because so many times fathers are sort of expected to be strong. They're seen to be supportive. And there's sort of this expectation of them just like jumping back into the reality. And so many times when I see a couple in the room together, I'll turn to the dad and I'll say, so what has this experience been like for you? And they'll say to me, you are the first person who has ever asked that question. And this is long after the loss of their child. So just remembering to, even though I get it, you're not necessarily counseling the parents, but when you're working with them to really understand the non-birthing person, the father, or the partner in the room, or the other parent, I should say. And this is what one father said. He said, I had to be strong. I was told not to show any emotion because it would upset her. It's funny, I was hurting too, and I was expected not to show it. So it's just important to really acknowledge that piece. So this is really something that's going to be important for all of you to recognize is how grief can manifest in the families that you're working with, right? I recognize again that you're not necessarily counseling these folks and you're not necessarily working with them through their grief or with their grief. But I just want to acknowledge that it's important for all of you to see how might this manifest with your families, which will inevitably then impact the children that you're working with. So withdrawal, the parent may be very withdrawn. You may notice a very deep sense of tearfulness or crying in the parent. The house may be unkempt. They may be very irritable. They may be very anxious. They may be struggling with sleep. A lot of anger may also be present. They may have a disturbance in appetite. You may notice a strong dysregulation in the parent and the child, right? So I'm sure all of you here know about co-regulation, and we know that if the parent's dysregulated, then the child is likely to be dysregulated. And also remembering too that the child may know that they lost a sibling, right? So depending on how far along they were in the pregnancy, some parents choose to tell their children very early on, others choose not to. So in many instances, the child will know that they have lost a sibling. And that's really important to acknowledge too, the child's grief and how to sit with them in that space. The parent may not necessarily be engaging in the exercises or activities, right, that you have provided them with to engage in. There may be a strong lack of self-care, a lot of sadness, like I mentioned, and lack of bonding between the parent and their child. So what are some supportive actions in grief, right? What are some things that you can be doing to really show up for the bereaved? So we're going to talk about acts of emotional caring, right? So really remembering the person who died, like I mentioned earlier, saying their name, right? Sharing memories. Again, I recognize in some cases there may not be a lot of memories, but I know that for my clients that say lost the pregnancy, we talk about their cravings during pregnancy, right? Those can be memories that we can talk about. Or, pictures of the ultrasound and maybe asking them, saying like, hey, would you like to show me some pictures of the baby? Right? Asking about some important dates, maybe the day that they were born, if they lost the infant, or asking about the time in which they found out they were pregnant and how that experience was like for them, right? And really using emotionally sensitive communication, which is like really compassionate communication. So saying things like, I am so deeply and profoundly heartbroken to hear about your loss. Very sick of hearing like, oh, I'm so sorry. I'm so sorry for your loss. So trying to be a little bit creative in the words and the language that you use, and trying to maybe express an emotion that you're experiencing, such as, I'm feeling so sad to hear about your loss. Emotional support, right? So really being present with them, allowing the expression of grief, not trying to grab tissues quickly and saying, here you go, like allowing them to grab tissues if they need to, or you can have a box of tissues there if they choose to take one. Really listening, being available. Again, I recognize not all of these are going to be applicable to you. Devoting time to them, being open to grief emotions. Some of them are going to express some really heavy and big emotions, not trying to fix or rush their grief, really trying to refrain from unsolicited advice. Last week, it was so surprising. I had a friend who's Jewish, and she was sitting Shiva. For those of you who aren't familiar, it's sort of like this time period that people I can't think of the term right now, that people have after the loss of a person, and people come and share that space with them, which is a really beautiful experience for the bereaved, to hear memories about their loved one and for people to be with them in their grief. And I paid a call to a friend of mine who lost her mom very traumatically, and it was horrifying to see everybody there talking about the loss of their parents and the loss of their loved ones. And it's like, but we're here to show up for this bereaved individual. We're not here to talk about your stories. There's time and place, like maybe a support group would be an appropriate place for that. So just thinking about perhaps not sharing your own experiences, your own stories, unless warranted, right? Unless the parent asks, or unless you feel like it's appropriate, because sometimes bereaved parents want to feel less alone, and sometimes you sharing your story can be valuable for them. But really being attuned to whether or not that's in the appropriate time for that. And then, of course, timeless support, right? So just unconditionally showing up for them. Instrumental support, so more like logistics, right? Assistance with childcare, doing meal trains, financial support, yard work, housekeeping, gifts, notes. And then, of course, more so appraisal support, like a sense of connection with others. Like I said, support groups, and also faith groups, schools, neighborhoods, etc. So I just want to take a moment to talk briefly about unhelpful grief support, right? Because again, for so many people, they're so well intended. And I always like to acknowledge that, because I don't think people are intentionally vicious and cruel. But it's important to recognize that there can be things that we say or do that are harmful to the bereaved, right? Such as judging their grief, telling them like, okay, not verbally necessarily, but like time to get over it, time to move on, or like, oh, well, everything happens for a reason, or at least you know you can be pregnant, you know, at least you know you can get pregnant, or you can try for another one, right? So just kind of being attuned to what you're saying. And one thing that I heard, which is great advice, is, you know, asking them how you can show up for them, but also saying things like, I'm thinking of you, versus asking a question, right? Versus saying like, how are you? Because come on, that's a very loaded question. And more often than not, it's, I'm feeling horrible. So rather saying things like, I'm holding you in my heart, right? Or I'm holding you and your baby in my heart. And I'm thinking of you. You know, you're on my mind today. I'm sending you love and compassion. So saying more so comments or remarks versus questions. So just really allowing the bereaved to know that you're there for them. Walking away from walking away from them, trying to change the subject. You know, trying to encourage them to participate in social events. Like many of my clients have expressed how they've gotten like invitations to come to baby showers. And it's like, that's not helpful. That's not being very sensitive to what I've just experienced. So again, also pathologizing their grief, right? Making them feel that there's something wrong with the way that they're feeling or the way that they're experiencing or expressing their grief. So before I move on to distress and grief following a child's diagnosis, I just wanted to check in to see if anybody had any questions. And again, I know that we went through this pretty quickly. I also want to be mindful of the fact that for a lot of you, this is not as relevant to the work that you do, but rather the fact that when you're working with a family, this could be something that they're experiencing, right? They could be experiencing the loss of a loved one. They could be experiencing perinatal and reproductive loss. And just being cognizant and mindful and intentional with it, right? When you're working with them, to show up to show up for them from a space of compassion and support, right? Rather than doing some of the unhelpful things that we've talked about, like pathologizing their grief or encouraging them to move on, or maybe, you know, saying comments to them like, everything happens for a reason. Like those are just things that are very unhelpful and deeply upsetting to the bereaved. And saying things like, you know, would it be okay if I asked you what your baby's name was or whether you knew what the gender was? And I promise you, every time I've asked somebody, would you like to share the gender of your baby? They will always say to me, you are the first person who ever asked me that. So asking permission, right? Because we want to do that from a trauma-informed way. We don't necessarily want to assume that they want to share with us the gender. Sometimes it's too painful. I've had clients that said, like, that's just too painful. I don't want to go there. And I honor that and I respect that. If you feel comfortable to do so, I really invite you to ask if they'd like to show you a picture. So many of them want to show pictures. It can be challenging sometimes to see a picture. It can be uncomfortable, because often the baby doesn't look very pretty when they've, you know, not been living for a while. You may look at ultrasound pictures with them, which again, for you, it's just a blob, but for them, it's like a cute, adorable, precious baby that could have, you know, lived. You might also want to ask them if they have any memories that they want to share with you, if they named the baby. So just thinking about ways that you can really honor and show up for them. And I can tell you from experience, it is so meaningful to them. And it's just these small acts that for you might seem insignificant, it might seem a little uncomfortable to look at a baby. You might also see if they want to show you the baby's footprints or handprints. These things are so painful. They are so painful to look at a precious little baby's footprints and to sort of sit with the idea like this baby's not living. But it is also so powerful for these families. So, shifting gears a little bit, because I know there's like sort of that one piece that's really focusing on perinatal grief and loss, but I really want to talk as well about the distress and grief that really comes up when a parent either learns about their child's diagnosis or that their child is struggling and not meeting their milestones, right? And I think this is very relevant to the work that you do. So many people, obviously experience grief when they learn about their child's either developmental or intellectual disability or challenge, right? When their child is not meeting their milestones. And again, similarly to what we talked about earlier, there's no correct or incorrect way to grieve. We just honor the grief for what it is. And this is an ambiguous loss. Again, right? A loss that has a deep sense of sadness and pain that's not associated with the death of a loved one. So there's this disenfranchisement. There's this sense of like, maybe I don't have a place to belong, or maybe it feels, so to speak, wrong to grieve because I haven't lost a loved one, right? And, again, like I said earlier, these feelings are so natural and normal given the abnormal circumstances. And that's what's so important for our parents to hear, is that these are normal feelings. And given how abnormal the circumstances are, and helping them recognize that it's so valid and so expected to be feeling this way. And many parents can feel isolated and lonely, again, like I said earlier, because their grief isn't socially recognized. We're not having a funeral service for the grief of finding out about a child's diagnosis, yet the grief feels just as real for them, just, in some cases, of course, as those that have lost a loved one. So I really want to talk about some themes of grief that you may notice or observe, right? Or that parents may struggle with. So parents may really struggle to identify or comprehend their feelings of grief. Again, because this is an ambiguous loss and because there's this enfranchisement in this grief, they may not even name it as grief. They may not know what it is that they're feeling. And it can be so helpful when we name that for them and they're like, yes, thank you for naming that for me. I had no idea that this is what I was experiencing. They may also notice a sense of abnormality or deviation from typical experiences, right? They may sort of feel like an outcast comparatively to their other peers or friends because they may not be experiencing the same thing. And parents will consistently and constantly be confronted with different reminders that their child isn't achieving the milestones in the way that others are, right? So they're constantly going to be grieving this loss. And they may experience triggers or cues. So a lot of people can't tolerate or despise the word triggers. So I like to use it interchangeably with cues if that feels more helpful, or activation. When observing, whether it be the child's siblings or the child's peers, reach different developmental stages or milestones. Again, there's also a mourning period, right, for the parent concerning regarding like what could have been, right? There's that loss of the potential, the loss of what this could have looked like. There's also a deep sense of like, this is not what I signed up for. Like, this is not what I wanted. And I really want to normalize that. I have a good friend who became a mom. And I think one of the most powerful things I ever heard her say was, I realized in the moment of giving birth to my daughter that I did not want to be a mother. Right. And being able to admit that and say, like, I did not sign up for this. I don't want to be a mother to this child. And giving them that permission to say that. It's not to say that they're not going to show up for their child, right? It's not to say that they're not going to be a good parent to the child, but giving themselves that permission to verbally express and say, like, this is not the parent that I signed up to be. I don't want to be a mother to this child. And then the question becomes, and perhaps that's where therapy can be beneficial. Okay, so now how do I work with this, right? How do I then work with the situation that I'm in, which is I don't want to be a mother to this child, and how can I learn to be a mother to this child, perhaps? There can also be, challenges with the child's behavior, right, related to the diagnosis, a lot of imagined future and worries and scenarios, right? A lot of parents, I have a client whose son was just diagnosed autistic, being terrified about him being bullied when he's older, right? So there's a lot of angst about what the future will look like, a lot of financial challenges. It can take a very big financial toll on families, and the lack of really social support and understanding. You know, I always hear parents say to me that they're very well-intentioned, you know, family members will say, oh, I'll grow out of it, right? And then how do we sort of sit with them in that space of, okay, so perhaps there is pathology, and maybe that's your job to really assess for that, right? But also, how do we sort of support them in the space of coming to that acceptance of their child's diagnosis, while also recognizing that not necessarily, I mean, in some instances, like a speech delay, right, or a speech impediment, there's room to recognize there can be progress, but this idea, like, we don't grow out of autism. So really just acknowledging that, and also the constant remarks around like, oh, everything's being so overdiagnosed today, right? And like, not to compare, but like, I have my son, I have a almost 5-year-old son, and he was diagnosed celiac. And like the number one comment we've been getting from people is like, oh, this day and age, everybody's allergic to everything. It's fine. I'm sure it's fine if he eats gluten. Like, sure, we're going to listen to what you have to say. So just recognizing that, you know, people I think are just very uncomfortable, similarly to what I said earlier. They don't want to imagine that their child could be diagnosed with these, you know, with these different concerns or issues. So it's so much easier to just not have to feel the pain or discomfort. Instead, I'm just going to avoid, maybe even blame, or maybe even say like, oh, we're going to blame the system. And you know, they're overdiagnosing. They're the ones causing all the issues. So I'm going to make a disclaimer. I despise the stages of grief, because I think there are no stages, right? I think when Elizabeth Kubler-Ross, the person who created the stages of grief, she did not intend for it to sort of be like I guess like a hierarchy, right? But rather, I think that's how it's been interpreted. And as you see this little infographic over here, you know, like what people accept, or sort of like what is portrayed, that you go through this cycle. But rather, the reality is you kind of go through this in many different ways. And it's not a linear path, right? We undergo it in any sequence and revisit the ones we've already experienced. People can feel denial and anger, react to denial, depression, anger, acceptance, bargaining. I mean, we really go through all of this. And for many people that learn about their child's diagnosis, they will experience this from the moment they receive the diagnosis, right? And there's likely a lot of shock in that. And I really appreciate this model that I read about there being 8 stages of grief with this. Again, we're not saying stages. Maybe we can say like experiences of shock, denial, anger, guilt, a lot of guilt we see in the room, depression, shame, acceptance, and empowerment. And I'm going to talk about this, you know, but I want to highlight for you that what I see in the therapeutic space is obviously a lot of shock and denial, anger, a lot of anger. So like I said earlier, you know, I work with a lot of clients that have experienced birth trauma or challenges during their pregnancy. And a lot of the time I'll see is a lot of blame toward their healthcare providers. So if I have a client, let's say, who experienced severe preeclampsia with one of her kids, and her doctor was dismissive of her symptoms, and she believes that's why her child's autistic today. Do we have the research supporting that? I don't think so, but that's her experience. That's her interpretation of it. And the guilt and anger that she experiences is unreal, right? The anger of, you know, the anger toward my doctor, like, how could he be so dismissive? And then also the guilt of, I could have prevented this. When we know in reality, we can't, right? So just understanding how these things can manifest for our families, that so many of them blame themselves for their child's, you know, issues or concerns. And many of them can also experience a deep sense of shame, you know, whether we like it or not, we all have our biases. We do. And many of us, even when we learn about our child's diagnosis, we experience so much shame around, first of all, shame with ourselves, right? But also shame with our child, right? So just being mindful and cognizant of that. And for the interest of today, we're really going to be using Elizabeth Kubler-Ross's model. And I want to highlight for you that this is not a linear path. I really appreciate these 8 stages. I think there's so much value to them. And I love the term of empowerment, which we'll kind of talk about with acceptance. So, the denial period, which again can also be shock, where a parent learns about their diagnosis and often their first mistake, their first thought is going to be like, this is a mistake, right? Like my child's fine. There's nothing wrong with them. They don't know what they're talking about. They misdiagnosed, right? This is not happening to me. And with invisible disabilities, right? Or things like a speech delay, often the grief and denial can look very different. The parent may refuse to accept their child's diagnosis, right, or challenges, and they may sort of shop around until they see the top doctor. I can't even tell you how many of my clients are like, I'm going to drive into New York City where they have the best doctors, and they get the same exact response, right? And denial is really there to protect them. But I want to highlight for you that sometimes this can be concerning because a person who is in such deep denial may really prevent their child from getting the appropriate services. And I think that's where there's tremendous value in very gently and compassionately guiding them through denial so that their child can receive the appropriate services, right? So first things first is validating and saying, I know how difficult this is to learn or hear about this. But we also know, and we have so much research. I mean, you guys are called early intervention, right? We know how valuable early intervention is and how beneficial it can be for long-term outcomes. So just showing up, validating and compassionately working with them so that they can get the appropriate services for their child. We also have anger, and you may notice the anger may be directed at you. And what I can tell you is, as someone who works with moms, I've had clients feel angry at me. And the anger is so, again, expected, but recognizing that after the shock wears off, many parents will experience anger, right? Because again, they don't want to believe that this is true. They don't want to believe that this is what's happening to them or their child. They may really blame themselves. Like I said, regarding my client who blamed herself for not going to a different doctor during pregnancy, they may experience a lot of guilt and shame, right? If only I would have done things differently. And it's really important to also recognize that sometimes their anger is a mask, and really there's a secondary emotion present, such as emotional pain and helplessness, right? They feel like they can't help their child. And the goal, again, can really be about tolerating their anger. I know it's difficult sometimes to be with someone while they're feeling so angry and irritable, but really trying to tolerate it and acknowledging their pain. And bargaining, right? We may see where the parent is trying to sort of do a little trade-off and say, like, I'm going to trade their health for mine, right? Or something similar to that. And not a lot of people go through bargaining, so you may not notice it at all. And then we have grief, depression, anxiety, right? Grief, depression, anxiety can all sort of coexist. And understanding that depression and anxiety can manifest in many different ways. Parents can experience a deep feeling of sadness, irritability, right? As their child continues to grow and develop, they may continuously re-experience these feelings. And many parents report symptoms of anxiety, right? They may be really, really anxious about their other children developing disabilities. And I want to highlight here for a minute that this is not going to be as relevant to, well, it actually is going to be very relevant to you. So one of the things that we see in the therapeutic space is how many of our clients are experiencing, and I know the topic of today is not about perinatal mental health disorders like anxiety and OCD, but many, many, many of our clients with extreme anxiety or OCD are hyper concerned about their children developing different disabilities, right? I kid you not, I have a client who her baby is 4 months old, and she decided that her baby's stimming and that her baby's autistic. She went to so many doctors, and they're all like, this is a baby self-soothing. This is what they're supposed to do. And this is not my only client. I have so many clients that are hyper concerned about their baby stimming, about their baby developing a disability. And it's really important that you, as early intervention workers, when you're noticing these clients are just completely resistant, to refer them to mental health providers. And I'm gonna share some great resources for that. But there are so many times when you're like, this baby's fine, there's nothing wrong with them. And I recognize you're not diagnosing them. But at the same time, there are so many of our clients that are having intrusive or anxious thoughts about there's something wrong with their baby, when there is nothing wrong with their baby. There's this hyper focus or hyper fixation on something is wrong with them. And they're just, requesting evaluations over and over again. And it's like, there's nothing wrong. And it's actually getting in the way of them being able to be a parent. So I would really strongly invite all of you to pay attention to that when you're working with your families. And there's even something called Munchausen syndrome, in which a parent, this is obviously in very extreme scenarios, in which a parent, projects a diagnosis onto their child. It's a very complex disorder I'm not going to get into, but just recognizing how parents can feel so incredibly anxious about their child potentially developing a disability, and they may really project that onto their child and may come to you continuously asking you to assess. And really, recognizing that acceptance and empowerment can happen, right? But for some people, they may never come to accept their child's diagnosis. And it can take a lot of time, and it's an ever evolving process. And what I like to think about is when parents are thinking about acceptance, many of them struggle with this idea of lack of hope. And what I like to think about is the idea of actions of hope. Because I think sometimes telling somebody to feel hopeful about something can feel unrealistic, whereas actions of hope can feel very powerful. So what I mean by that is, if a parent truly did not believe that their child wasn't going to eventually accomplish certain milestones, or is not benefiting in some sense from their therapy, then they wouldn't be taking their children to their doctor's appointments or to their therapy appointments. And I like to recognize going to your doctor's appointment, going to your therapy appointment is an action of hope. That is me believing that something is going to come from this. Maybe it's going to be something extremely small and insignificant, but those things are actions of hope that are so valuable and important for us to recognize. And we see this a lot in the therapeutic space when people struggling with anxiety during pregnancy, they're so anxious their baby isn't going to live. And we say, hey, you're doing an action of hope. You're going to your doctor's appointment. If you truly believe this baby was dead, you wouldn't be going to the doctor's appointment. And the same could be applied here. So really highlighting for them that by engaging in these appointments and experiences, they are engaging in actions of hope. And also, not necessarily does everybody have their happy ending or the happy ending in which they envisioned for themselves. And just being able to recognize that we tend to sometimes have this illusion that, like, I'm going to have my happy ending. My child's going to grow up and be the president. And yes, maybe they will. Maybe they will. We like to believe that people can be whatever it is that they want to be. And recognizing that while also holding on to the fact that they may not necessarily have the happy ending in which they had envisioned. And that's where acceptance can be. Learning about the fact that even if we don't have this perfect happy ending that we envisioned, we will be okay. We will be okay. I will live. I'm noticing that I'm breathing, and I will be alive to tell the story. So I recognize that we're like 10 minutes out, and I want to save time for questions. So I'm going to go through this really quickly, but this is a really invaluable piece. I just wanted to recognize again, and I want to reiterate about the OCD and anxiety piece about these intrusive thoughts and paying attention to them. I also want to acknowledge that, when we talk about maternal bonding, we do have research to say when there's a lack of maternal bonding, there is that risk for developmental delays. And by you getting these parents into seeing therapists or psychiatrists or getting access to different services, we're really helping them with bonding, which inevitably will be a protective factor against developmental delays in some sense, of course, right? Because there's so many other issues that we always have to recognize when it comes to somebody developing issues. But just wanted to speak to the fact about bonding. So I'm not going to get into this. All of this is honestly in that drive that will be shared with all of you. But, you know, when you're parenting a child, just recognizing that it's so valuable to come from a culture of calm. And I really like the approach from the pathological demand avoidance perspective, which is, we know, often with autism, but I think it can be with any emotionally dysregulated child. And let's be real, which child is not dysregulated? And I think it could be a really great model. I sent a sheet that has like the entire the entire breakdown of the approach. Neurodiverse accepting parenting. Honestly, I think all of us as parents, regardless of whether or not our children are neurodiverse, we should be parenting from this perspective. It's a very valuable, compassionate approach. And asking, and really parents should be asking themselves, like, is this a behavior that needs to be changed? Like, is this my own need or is it my child's need? And I think that's a very important lesson to teach our parents. And I want to talk so much more about this, but I also want to save time for questions. But again, there's a whole handout on this PANDA approach, and I really invite you to look through it and read it, as it's very valuable. This is a great TED Talk. I don't have the time to show it, but look it up. It's so wonderful. It's going to play. 1 second. Okay. It's called How to Do Laundry When You're Depressed. So I really want to take a moment to really talk about the hierarchy of needs and recognize that for our parents, their basic needs need to be accessed first before we talk about any sort of psychological needs, right? Where when we're working with our clients, with our families, we need to recognize that they need to have sleep, they need to be eating, they need to be nourishing their bodies and addressing their concerns before we can even talk about psychological needs. And sometimes it can be very beneficial and helpful when we really encourage our parents and say, you know, why don't you go grab a bite while we're doing this? Or why don't you go grab a drink? And I can't even tell you how many times my clients have told me, oh, I'm realizing that I have not gone to the bathroom the entire day. They've been holding it in because they haven't had a moment to themselves. And really just tapping into that and acknowledging and helping them recognize, like, we need to access your physical needs first before we even talk about how you can show up for your child. Again, I can talk about this for a million years, but please be mindful of those physical needs. I also really wanted to talk about unmet needs, that so many times we talk about mom rage or moms being incredibly irritable and angry, and rather what they're really experiencing are so many unmet needs. And that's really where it ties really well into Maslow's hierarchy of needs when we talk about our basic needs not being met. So perhaps encouraging them to get their needs met. So this is probably one of the most important pieces that I want you to take away with, which is how you can really encourage your parents to engage in self-care. And I really love the idea of micro moments, you know, of really redefining self-care, that sometimes when we add things to our to-do list, it can feel incredibly difficult to get them accomplished. And quite frankly, it feels like we have more to do on our list. So micro moments is when we find these very, very small moments in which I can notice myself feeling slightly more calm or I'm able to breathe. So for example, if a mom is dropping off her kid at school and she's at a red light, can she just take a moment to orient herself and breathe, right? When she's brushing her teeth, can she be mindful and cognizant of the fact that, like, I'm brushing my teeth, I'm noticing the smell of the toothpaste, I'm noticing that I'm taking care of myself by nourishing my body, by taking care of my hygiene, showering themselves with their favorite soap, leaving the shower on for like a couple of minutes longer, just so that they're taking that moment to themselves, sitting on their porch for like a minute. Again, it's about finding those micro moments. It's not about finding a minute or 30 minutes in their day. It's about finding a very, very small amount of time, 30 seconds, a minute if they can, to just take a moment with themselves. Mini vacations. I also love this. This is from DBT, which is them going on a mini vacation with themselves, right? Going to the bathroom with the door locked for 5 minutes. The children will be okay. I had a client yesterday visualize that she was in Spain, and that was her mini vacation for 5 minutes. Going into the car and blasting music. One of my clients, she makes her mini vacation is going to get an iced coffee at Starbucks every day and just being with her iced coffee and really being with herself while she's drinking it, not waiting for all the ice cubes to melt until she finally finishes it, right? Really, I used to buy, honestly, toys for my son that were a present for myself. Like, for example, I would buy him, I don't know, making up, let's say like Play-Doh. And the idea of the Play-Doh was not for him, it was for me, because I knew it would keep him entertained for 5 minutes. And those 5 minutes, I can actually breathe. So just thinking about like ways that I can go on a mini vacation. Respite is so important. And I really like to explain to clients and parents that, respite can include childcare, right? Such as paid childcare if you can afford it, but also sometimes it can be a TV if you need to, right? It could be a toy. Like I said, buying your kid a toy or having them play with a toy, books, having a partner, family member, etc. It's really about redefining how I take respite and how I identify my childcare. Who can be, so to speak, like my new co-parent? That's exactly what we call it. That's the word I'm looking for. Co-parent. We talk about finding things that can be your co-parent. Sometimes it's objects and sometimes it's humans. Movement, right? Not exercise, movement. If they can park their car further down the block, walking to the mailbox, just taking a little stroll if they can. So redefining that as movement, going to Target alone, getting their favorite coffee or their favorite snack. I've had clients say, like, I just want a delicious, like warm, nurturing person to make me food. So we'll say, like, can you order your favorite takeout tonight? Like, can that be your warm, nurturing food for yourself? Getting sunshine and then connecting with others. So there's some great resources. This is like a handful. I put so many in a Google Doc in the Google Drive that will be shared with you. If any of you need to make referrals, we have the lovely folks from the consortia here that can help you. But we at Postpartum Support International, we have support groups, we have consultation, we have mentorship, we have coordinators such as myself, where I help people find therapists, support groups, psychiatrists, etc. So you can always feel free to send them the information, which is in the Google Drive, and they can access those resources. So I'm sorry for brushing through that so quickly, but I just wanted to check in to see if anybody had